these partnerships that are going to be a critical part of the implementation, there is no more important partnership than that between the Department of Health, the HSPs, primary care and consumers. So I do want to pick out the components of the recommendations that particularly emphasise those partnerships. Let me take the strategies one by one. Excuse me. First of all, public health. Now, we're aware of the problems of obesity within the community. About two-thirds of our adults are now either overweight or obese, about a quarter of our children. And although the emphasis in the Sustainable Health Review was perhaps towards early childhood, there's no doubt that we have to address the problems of obesity across the whole generation. It is a major risk factor for cardiovascular disease, type 2 diabetes, which there's an epidemic, and increasingly recognised as a major risk factor for cancer. So together we're developing the Healthy Weight Action Plan for WA, which we hope to deliver towards the end of this year. And together we've developed the Obesity Collaborative, which is going to look at the problem all the way through from prevention to ultimately bariatric surgery and how we might manage the wait lists around that. So these are important, large projects that are being coordinated between the Department of Health, the HSPs, and the other players that I've mentioned. The importance of primary care in attacking this problem, because we can all be a little bit fatalistic about this. We can all think, oh, let's just put on a sugar tax and deal with it that way. The importance of primary care was recently brought to the fore by studies out of Glasgow, which showed that in up to 50% of cases, you could actually reverse type 2 diabetes associated with obesity through primary care interventions. And that is now being rolled out through the NHS. So they're trying to cut down that 17-year gap between the evidence appearing and the intervention being applied through the system. Of course, we haven't dealt with all the other problems. We mustn't lose sight of that. But the focus for the Sustainable Health Review initially was on obesity. Smoking remains the major risk factor for shortened lifespan. It remains the major risk factor here and in WA. Alcohol is now no longer thought to be protective in low doses to cardiovascular disease. It's now become clear that alcohol at whatever dose is hazardous. It's also become clear that alcohol is a significant contributor to cancer. So these are areas which we also have to address through public health measures. Mental health. You can see in the diagram on the left-hand side that mental health is a significant contributor to disability. It's a major contributor to, in this case, years lived with disability, or in some we could show other ones for DALYs. But it's important to recognise that mental health problems don't arise in isolation. And it was Darcy Holman and his team which in the mid-90s first drew attention to the real problems of the physical illnesses associated with patients who also have mental health problems. And we have done insufficient in that time to address those problems. And that's an area, again, which I think we should begin to focus on more. I haven't dealt with the problems of justice health, but that is another area where we're really behind the rest of the world. Clearly, problems of mental health are particularly common in those who are incarcerated. Often they contribute to the patients being incarcerated, and we are just not doing enough to ensure that the healthcare is seamlessly coordinated through the whole continuum of care. So this emphasises that the disability associated with mental health predominantly affects people in the younger years, in the working years, when they're at their most productive. So this is clearly a focus that we have to have. At the moment, we have about 14,000 admissions per annum associated with mental health problems, many of which could be avoided. We spend about $400 million on hospital care for mental health problems. And the recent studies out of the Office of the Auditor General have shown that about 90% of that care is delivered to 10% of people with mental health problems. So we've got an enormous burden, which I'm sure through coordinated care could better be managed in the community. Now, beginning and end of life, it's become quite clear that the first 1,000 days are critical to set the trajectory for the life course thereafter. Studies have shown that genetic implanting in the womb is critical to switching genes on and off, and those can have effects on the prevalence of chronic diseases in later life, cardiovascular disease, diabetes, even osteoarthritis. So getting that right is important. Getting maternal health right is important. Preparing people for pregnancy is important, and there's no more important community than the Aboriginal community to get that right. And we're doing some work, really supporting the work of Rhonda Marriott around birthing on country and how that can be done safely. If I move to the other end of life, we know that there's a lot of futile care that is delivered towards the end of life. We know that that is not necessarily what patients want. Yes, there are fantastic advances in precision medicine, which I'll deal with in a minute or two, which offer cures to patients who otherwise wouldn't have been cured, with a whole range of different cancers now. But what people often want is symptom control, palliative care, and this has been an important outcome of the Joint Select Committee report. We have taken on the need to improve palliative care, particularly for those in remote and rural areas. The government is committed to $41 million going forward, a good chunk of which, 30 million of which, is to deliver services better in remote and rural areas. So that clearly involves primary care. I'm delighted to see Silver Chain represented here because of the fantastic work that they do. We heard at the Palliative Care WA breakfast the other day how about 75% of healthy people might choose to die at home. But actually, the preferences change towards the end of life when you're confronted with it. And really, people just want to be cared for, to have the symptom control in the right place at the end of life. But I think it's quite clear that the involvement of the family GP is absolutely critical to ensuring that that is the best possible experience for the patients and their families. We're doing work around the goals of care and advanced health directives, particularly in collaboration with My Health Record, the ADHA. We're going to be one of 2 jurisdictions which are beginning to pilot the uplift of advanced health directives into My Health Record, and I'll come back and talk about that a little bit more. Goals of Care is very much part of our high-value healthcare collaborative, where we're looking to begin to reduce our investment in interventions which have very little clinical value, certainly don't affect outcomes, and shift our emphasis into those which do. Voluntary assisted dying has obviously had a lot of press recently, and I'd be very happy to take questions on that later on, but I don't want to emphasise it just at the moment because there's so much else to consider. But the Ministerial Expert Panel is going to be reporting very shortly, and there is a real momentum to delivering a bill to Parliament within the next few months. So that is the focus of our team at the moment, and I'd like to acknowledge the work of the Palliative Care Network in particular, and Karen Bradley and her team in clinical in clinical leadership and reform directorate within my division. And then we've also got the Royal Commissions. There's one into disability and there's one into aged care, and it would be a real concern if the involvement of general practice in the aged care community was in any way diminished as a result of the findings of the Royal Commission. I'm not going to talk about NDIS. I'm sure that many of you are aware of some of the, shall we call, teething problems associated with NDIS are out there. A lot of our patients are struggling, and I'm sure that you're all struggling to actually get your head around the organisation of this as well. But this is a key priority for the department over the next 12 months or so. The next strategy is around equitable access. Now, there really is nothing new about telehealth. It's been in WA for 25 years or so. I've been delivering telehealth services to Albany in the Kimberley region for more than 20 years. But what has changed is the technology has improved, the connectivity has improved, the interest among the specialists has improved, and the coordination has improved. So we're now being able to reach out into the community much more effectively. We know our emergency telehealth is second to none in the world, and I'd have to acknowledge the work of Andrew Wesseldine and his team in developing our telestroke facility, which is now delivering excellent outcomes to those who have cerebrovascular disease in more remote regions. We're in the process of developing a command centre in order to coordinate the care of patients in these remote areas, particularly if they require transfer. And of course, there's a whole national programme around the development of rural generalists to try and get more expertise out there into the community. And I'll come back to that when I talk about general practice and the workforce. Funding and planning. Leanne earlier talked a little bit about commissioning. There are great opportunities for us to work together around joint commissioning. There is a project to be established in the Kimberley around this. We need to inform how we spend our money, and it's often been based on historical precedent. We need to have a plan, we need to have a way forward, we need to have some outcomes that we're going to achieve, and then have that inform the commissioning. Urgent care clinics. Hopefully will take some of the pressure off our emergency departments. The burden of chronic disease is enormous, as I've alluded to when talking about obesity, and presentation to the emergency department with a preventable condition is a failure of the system. The work by Alistair Vickery and his team, primary care at UWA, has shown that up to 40 or 50% of the patients that they were reviewing in emergency departments could have been managed in general practice, some of them with additional resources having been added. So there are enormous opportunities to move patients away from the front door. Unfortunately, that's where our emphasis is, that's where the metrics are, that's where the press is focused. But we need to actually begin to move into other areas. So the urgent care clinics, or the urgent care network, is a way in which the department has worked together with HSPs, has worked together with the primary care sector, WAPHA in particular, the colleges and AMA, to come up with this concept of using existing capacity in order to see people urgently and avoid hospital presentation. Now, I talked about how we might plan, how we might direct our attention in a more focused way. There's a lot of focus on big data these days. There's a lot of focus on precision health, and I see one of the architects of precision health, Hugh Dawkins, sitting before me. I think he would like me to talk about precision public health, and this is an example where using new technologies, and this is by the Chasm Group at UWA, for instance, we can pinpoint with great accuracy where our hotspots are. The sort of presentation on the left-hand side is the sort of standard chloropleth methodology, which gives us an idea of where the problems are. But the new technology is being much more specific, much more directed, and we could direct our services much more appropriately. This shows, for those of you who don't recognize it, a convolutional neural network. This is very high-tech stuff. This is coming to your practices now. You're probably using it, although you might not be aware of it. This is work by Google, published in one of the most prestigious journals, Cell, beginning of last year. This sort of technology is now being used. Certainly the first trial of its use in general practice was here in Midland. All right, and this was a collaboration between CSIRO and general practice out there. So this technology, which was developed here, it's not the same as the Google stuff, but similar technology was developed